আমরা ডাইউরেটিক্স আর অ্যান্টিডাইউরেটিক্স পড়েছিলাম, তার মধ্যে কি কি টপিকস কভার আপ করা হয়েছিল? সরি, loop diuretics and antidiuretics. Okay, we discussed about the general introduction about the diuretics, the drugs that are included in the diuretics, and also about the loop diuretics and the thiazide and thiazide like diuretics. Now today we will cross over all other diuretics and then we will discuss about the antidiuretics and their preparation. Now coming to the next group of drug, carbonic anhydrase inhibitors. We all know there is an enzyme called carbonic anhydrase that basically catalyzes the reaction bicarbonate to carbon dioxide and hydrogen and water. They basically catalyzes H2O plus CO2 to bicarbonate H2CO3. The reaction occurs spontaneously but in a slower rate, and this enzyme is responsible for the increase in the rate of the reaction, okay, by way, in the both way. Now carbonic anhydrase is an enzyme which catalyzes the reversible reaction H2O plus CO2 to carbonic acid. Carbonic anhydrase thus function in carbon dioxide and the bicarbonate transport and H plus ion secretion. This enzyme is present in the kidney, in the proximal tubular cell especially, where they are present in the brush border of the luminal membrane of proximal tubule. They are also present within the proximal tubular cell. Okay. Now they are also present in the gastric mucosa, exocrine pancreas, in the ciliary body of the eye, in the brain, in the RBCs, etc. In these regions, basically to show the effect, the carbonic anhydrase inhibitors, to show the effect, 99% inhibition of the enzyme inhibition is required. Now coming to the acetazolamide, is a prototype drug in the carbonic anhydrase inhibitors. Where does it act in the kidney? They act particularly in the proximal tubule. So their site of action is site 1. Okay. It is a sulfonamide derivative which basically inhibit carbonic anhydrase enzyme in the proximal tubular cell. Within the proximal tubular cell, the carbonic anhydrase enzyme present is type 2 isoform, and the enzyme which is present in the brush border in the luminal membrane of proximal tubular cell, that is of isoform type 4. Now they are inhibiting type 2 isoform of the carbonic anhydrase enzyme in the proximal tubular cell and resulting in slowing of hydration of the carbon dioxide, resulting in the formation of carbonic acid. Now as H plus and now you see is a carbonic anhydrase 2 isoform in the proximal tubular cell, that is resulting in the hydration of carbon dioxide to H2CO3, resulting in the formation of hydrogen ion and bicarbonate ion. Now as the enzyme is inhibited, the availability of H plus ion to exchange with the luminal sodium through the sodium hydrogen antiporter, this enzyme sodium hydrogen antiporter is decreased. Again the inhibition of carbonic anhydrase enzyme isoform type 4 present in the luminal membrane of the proximal tubular cell. What happens? This is a carbonic anhydrase 4 enzyme. It results in the basically metabolism of carbonic acid to H2O plus CO2. So inhibition of brush border CAs result in retards dehydration of carbonic acid in the tubular fluid, so that less carbon dioxide is available to get diffused into the cell. The net effect is তাতে কি হবে? The net effect is decrease in bicarbonate absorption. So The net effect is inhibition of bicarbonate reabsorption in the proximal tubule. তো তাহলে কি হতে পারে, নাম্বার 1 bicarbonate reabsorption টা কমে যায়, তো more and more bicarbonate is being excreted in the urine. That means that will result in acidosis in the body. So however the urine become more alkaline. However, the resulting alkaline diuresis is only mild. Why mild? Because maximal fractional sodium loss is 5% here. Because part of the sodium rejected in the proximal tubule is reabsorbed in the high capacity ascending limb of loop of Henle. So the secretion of H plus in the distal tubule and collecting duct is also interfered. Why? Because although the secretion of H plus in the distal tubule and in the collecting duct are done by H plus ATPase enzyme, but the formation of H plus in the cell is done by the carbonic anhydrase enzyme. So there also the drug has got action, so they are decreasing the formation of H plus ion to be available. Okay, so secretion of H plus in DT and CD is also interfered. Though H plus is secreted at this site by H plus ATPase enzyme, it is generated within the cell by carbonic anhydrase mediated reaction. As such, this is a subsidiary site of action of basically of the drug. So primarily they have got action in the site 1 proximal tubule. Secondarily, they have got action also on the collecting duct and the distal tubule. When carbonic anhydrase inhibitors are given, the distal sodium exchange takes place only with potassium, which is lost in excess. As the sodium basically giving of carbonic acetazolamide result in natriuresis, so more and more sodium is available in the distal tubule, so that is more and more exchange with potassium ion. So what happens? Caliuresis occurs, and this caliuresis is more prominent than the use of other diuretics. So for the same degree of natriuresis, carbonic anhydrase inhibitors cause the most marked caliuresis compared to other diuretics. Loop diuretics, thiazide diuretics তার থেকে বেশি কিন্তু potassium loss করে acetazolamide. The urine produced under acetazolamide action is therefore alkaline, mild alkaline urine, rich in bicarbonate, which is matched by both sodium and potassium. Continued action of acetazolamide. What happens? If the acetazolamide is used continuously, then more and more depletion of bicarbonate stored in the body occurs. Now, the diuretic action of acetazolamide is dependent on the bicarbonate present in the urine. So what happens? If less bicarbonate is available in the urine because of depleted body bicarbonate stored, then what will happen? Less diuresis will occur with continued use of acetazolamide. So it shows self-limiting diuretic action with continued use of the drug. Now, other than the renal action, as the carbonic anhydrase enzyme is present in other tissues also, it also shows extra renal effects like lowering of intraocular tension due to decreased formation of aqueous humor, which is rich in bicarbonate. So this drug is used in acute congestive glaucoma. Why? Because it decreasing the formation of aqueous humor, so intraocular pressure is lowered. Decreased gastric hydrochloride and pancreatic sodium bicarbonate secretion, but this effect is shown with very high dose of acetazolamide. The dose used clinically does not show this effect. Raised level of carbon dioxide in brain and lowering of pH, that result in sedation, and they raise the seizure threshold. So this drug is even can be used in basically akinetic epilepsy when the other drugs are not effective that much. Alteration of carbon dioxide transport in the lungs and tissues, these actions are masked by the compensatory mechanism. Pharmacokinetics, well absorbed orally, excreted unchanged in urine, action lasts for 8 to 12 hours. Usage of acetazolamide or the carbonic anhydrase inhibitors. Number 1, in glaucoma. Well, as a diuretic is not commonly used acetazolamide. Why? Because of the acidosis it produces, the higher amount of hypokalemia it causes, and it is not used, so it is not used as a diuretic clinically, but it is used in glaucoma patient, in acute congestive glaucoma, as an adjuvant to other ocular hypotensives. It can be used to alkalinize urine in case of certain poisonings by acidic drugs, so that the drug can be faster, quickly eliminated from the body. And in case of urinary tract infection, it may be used to alkalinize urine. Number 3, epilepsy in absence seizure, to as an adjuvant to other drugs. Acute mountain sickness mane high altitude basically dizziness, headache, nausea, vomiting gulo hote pare. So it is a drug of choice for symptomatic relief as well as prophylaxis. Benefit occurs probably due to reduced cerebrospinal fluid formation as well as by decreasing the brain pH. It can also be used in periodic paralysis. Adverse effects are frequent: acidosis, hypokalemia, drowsiness, paresthesia, fatigue and abdominal discomfort. Hypersensitivity reactions may be seen. Bone marrow depression is rare but dangerous. It is contraindicated in liver disease because it leads to the because basically it interferes with the urinary elimination of ammonia due to alkalinization of urine, and so it can precipitate hepatic coma. Acidosis is more likely in patients of COPD, so should be cautiously used. Now coming to the next group of drug, potassium-sparing diuretics. There are two group of drugs here. Number 1 is aldosterone antagonist, that include spironolactone and eplerenone, and number 2 group of drug is sodium epithelial sodium channel inhibitors, that include amiloride and triamterene. Okay, so coming to the first drug, spironolactone. Spironolactone basically is the prototype aldosterone antagonist. It is structurally related to the mineralocorticoid aldosterone. What does it cause? Basically, aldosterone, this is a basically is a late distal tubule in the collecting duct cell, where aldosterone, they basically enter via the basolateral membrane. Aldosterone, it binds to the mineralocorticoid receptor and leads to the formation of the hormone responsive mRNA, that leads to the formation of the aldosterone induced proteins AIP, and that is causing the subsequent effect. What are the effects? Basically, so aldosterone penetrates the late distal tubule and the collecting duct cells, act by combining with the mineralocorticoid receptor, induces the formation of aldosterone induced proteins. These aldosterone induced proteins, they promote sodium reabsorption. Aldosterone is causing sodium reabsorption by a number of mechanisms and potassium secretion. Now what does spironolactone is doing? Spironolactone is the analog of the mineralocorticoid aldosterone. It also enters the interstitial side of the tubular cell. It binds with the mineralocorticoid receptor competitively with the aldosterone and inhibit the formation of AIPs, aldosterone induced proteins. So in a competitive manner, it has no effect on sodium and potassium transport in the absence of aldosterone. While under normal circumstances, what does it will cause? It increases sodium excretion and decreases potassium excretion. Now, spironolactone is a mild saldiuretic because it is acting at the late distal tubule and the collecting duct, and the majority of the sodium has been already absorbed in the proximal tubule and the ascending limb of loop of Henle. So it's a mild diuretic because majority of the sodium has already been reabsorbed proximal to the site of action. However, it antagonizes potassium loss that is induced by the loop diuretics and by the thiazide diuretics. So it antagonizes potassium loss and slightly add to their natriuretic effect. And definitely in case of refractory edema, it is very helpful. That is caused by secondary hyperaldosteronism. Like in case of cirrhosis of liver, the aldosterone level goes up. In those patients, the normal diuretics like loop diuretics, like the thiazide diuretics, they may not be effective. But when they are added up with spironolactone, the edema disappears. The potassium retaining action develops over 3 to 4 days. The spironolactone increases calcium excretion by a direct action on the renal tubules. Oral bioavailability for microfine powder is 75%. Well, it is highly plasma protein bound, and the most important thing is that it is completely metabolized in liver. To active metabolites, one of it is canrenone, which is longer acting and basically responsible for half to 2/3 of the action of spironolactone in vivo. The T half of spironolactone is 1 to 2 hours and that of canrenone is 18 hours. Now coming to the usage of spironolactone is a weaker diuretic. So it is not commonly used as a single diuretic. It is generally combined with other more efficacious diuretics. Where? Number one, to counteract potassium loss due to the thiazides or the loop diuretics. Okay. Number two, it is more preferred in the refractory edema, like in case of cirrhosis of liver, in nephrotic syndrome, where the edema does not subside due to the secondary hyperaldosteronism. So it is more useful in cirrhosis and nephrotic edema, in which aldosterone levels are generally higher. Spironolactone is frequently added to thiazide or the loop diuretics in the treatment of ascites. It breaks the resistance to thiazide diuretics that develops due to secondary hyperaldosteronism and reestablishes the response. Thus, it is particularly employed in refractory edema. Number three, hypertension. Now, it is used as an adjuvant to thiazide to prevent hypokalemia in patients of hypertension. They also attenuate hypertension related renal fibrosis and ventricular or vascular hypertrophy. They are also used in congestive heart failure. Basically, in congestive heart failure, the diuretic of choice is spironolactone or the aldosterone antagonist, because they are linked with improved survival. So, as additional drug to conventional therapy in moderate to severe CHF can retard disease progression and lower mortality. Other diuretics does not improve mortality in congestive heart failure. It is aldosterone antagonist that is showing improved mortality. Now, interaction, as this drug is causing decreased potassium loss, so given with potassium supplement, dangerous hyperkalemia may occur. Number two, aspirin. Aspirin blocks spironolactone action by inhibiting tubular secretion of its active metabolite canrenone. Canrenone was responsible for half to 2/3 of action. As the tubular secretion of canrenone is prevented by aspirin, so the canrenone concentration increases in the body and thus it is blocking spironolactone action. কেন কি ইউরিন আসতে হবে ক্যানডিডন কি কাজ করার জন্য. More pronounced hyperkalemia can occur in patients receiving ACE inhibitor ARB. Why? Because these drugs already cause hyperkalemia. When combined with spironolactone, dangerous hyperkalemia may occur. Spironolactone increases plasma digoxin concentration. How? Spironolactone causes hyperkalemia and hyperkalemia causes increased digoxin level. Hyperkalemia causes increased digoxin level. Hypokalemia causes increased digoxin toxicity. Adverse effect. The side effects are drowsiness, ataxia, mental confusion, epigastric distress and loose motion. Spironolactone interacts with progestin and androgen receptors as it is mineralocorticoid, basically structurally related to mineralocorticoid. They interact with steroid receptors, other steroid receptors like progestin and androgen receptor. In addition, it increases or enhances testosterone clearance or its peripheral conversion to estradiol. So what may happen in men, basically it can lead to hormonal side effects like gynecomastia, erectile dysfunction, loss of libido. In female, it can cause breast tenderness or the menstrual irregularities. Most serious is hyperkalemia side effect, among the side effects that may occur, especially if renal function is inadequate. Peptic ulcer may be aggravated, so it is contraindicated in peptic ulcer patients. Now coming to the second aldosterone antagonist, Eplerenone. Action more or less similar to spironolactone, but it has got much lower affinity for other steroidal receptors. So the hormonal related side effects are lower with Eplerenone compared to spironolactone because it is more selective for aldosterone receptors than with other steroidal receptors. These features make it particularly suitable for long-term use in the therapy of hypertension and heart failure. However, the risk of hyperkalemia and gastrointestinal side effects are similar to that of spironolactone. It is well absorbed orally, inactivated in liver by CYP3A4. So, excreted in urine as well as in feces. So, as it is metabolized by CYP3A4, if it is taken along with CYP3A4 inducers, so what will happen? More metabolism, the level will decrease. If it is taken with inhibitors of CYP3A4 like azole antifungals, like macrolides, then its level will increase. Eplerenone is indicated specifically in moderate to severe congestive heart failure, post-infarction left ventricular dysfunction and in hypertension. Now, coming to the next group of drug, inhibitors of renal epithelial sodium channel. So, two drugs are there, amiloride and triamterene. These are two non-steroidal, spironolactone and aldosterone, eplerenone. They were steroidal, steroidal drugs, but these are two non-steroidal organic bases with identical action, but the site of action is different slightly. Their most important effect is to decrease potassium excretion, so they cause hyperkalemia, particularly when it is high due to large potassium intake or use of a diuretic that enhance potassium loss. This is accompanied by slight increase in sodium excretion like that of spironolactone. The excess urinary sodium is matched by chloride and variable amount of bicarbonate. Urine is slightly alkalinized. The effect of urinary electrolyte pattern is superficially similar to that of the spironolactone. So, increased sodium excretion, decreased potassium excretion, but their action is independent of aldosterone. Calcium and magnesium excretion is also reduced, but there is no effect on renal hemodynamics. They act from the luminal membrane of the late distal tubule and the collecting duct, which express renal epithelial sodium channel that is linked to basically or amiloride sensitive sodium channel through which sodium enters the cell down its electrochemical gradient, which is generated by the sodium potassium ATPase present in the basolateral membrane. So, what happens when this enzyme is inhibited? Less sodium reabsorption and more sodium excretion. Now, this sodium entry partially depolarizes. Now, what happens? This is the basically sodium channel, basically amiloride sensitive sodium channel or the renal epithelial sodium channel. What happens? It helps in absorption of sodium down the electrochemical gradient which is developed by the sodium potassium ATPase pump in the basolateral membrane. Now when the sodium is reabsorbed, there is transient generation of transepithelial gradient 15 millivolt. This is on the minus side, this is on the plus side, and that help in potassium excretion through the potassium channel. Now when amyloride is inhibiting this channel, the sodium is not reabsorbed, more sodium excretion, the transepithelial gradient is not formed, so less potassium excretion. That is the mechanism by which it is helping in preserving potassium. So this sodium entry partially depolarizes the luminal membrane, creating a minus 15 millivolt transepithelial potential difference, which promotes secretion of potassium through the potassium channel. Though there is no direct coupling of sodium and potassium channels, more delivery of sodium to the distal nephron, greater is its entry through the sodium channel, more development of the transepithelial gradient, and more potassium excretion. As such, all diuretics acting proximally promote potassium secretion. Amyloride and triamterene, they block the luminal sodium epithelial channels and indirectly inhibit potassium excretion. While the net excess of sodium loss is minor, because there is only small fraction of the total amount of sodium that is excreted in urine. Sodium natriuresis effect is smaller রয়েছে কেন কি already most of the sodium has been reabsorbed from the proximal tubules and the ascending limb of loop of Henle. The intercalated cells in collecting duct possess collecting duct as একটা H plus ATPase enzyme আছে that will basically that is secreting H plus ions by taking in sodium ions. Now what happens? This pump is facilitated by the lumen negative potential. Amyloride, by reducing the lumen negative potential, they also decrease H plus ion secretion and predisposes to acidosis. Thus, amyloride conserves both potassium and hydrogen ion while marginally increasing the sodium excretion. Uses in conjunction with thiazide type of or high ceiling diuretics like that of Spironolactone to prevent hypokalemia and slightly augment the natriuretic response. Also, it augments the antihypertensive efficacy of the thiazide. Now, adverse effect like that of Spironolactone, risk of hyperkalemia is there. So, should not if it is used with potassium supplement or ACE or ARB, dangerous hyperkalemia may occur. With beta blockers NSAIDs with renal impairment, hyperkalemia chances also there. It should not be used with potassium supplement. Both drugs elevate plasma digoxin level because of hyperkalemia. Triamterene, it is incompletely absorbed orally, partly bound to plasma proteins, largely metabolized in liver to an active metabolite and excreted in urine. Plasma half-life 4 hours, effect of a single dose 6 to 8 hours. Side effects are infrequent: nausea, dizziness, muscle cramp, rise in blood urea. Impaired glucose tolerance, photosensitivity may be seen. Coming to amyloride, it is 10 times more potent than triamterene. At higher doses, it also inhibits sodium reabsorption in the proximal tubule. It decreases calcium and magnesium excretion but increases urate excretion. So, hypercalcemic action of thiazide may be augmented, but what does thiazide do? It causes hypercalcemia and hyperuricemia. When it is combined with amyloride, hypercalcemic action may be increased, but the hyperuricemic action of thiazide will be blunted. Only 1/4 of the drug is absorbed, half-life 20 hours, duration of action longer than triamterene, not bound to plasma protein, not metabolized. Amyloride blocks entry of lithium ion through the sodium channels in the collecting ducts. So basically they are the drug of choice. in lithium-induced diabetes insipidus. Given as an aerosol, it also affords symptomatic relief in the cystic fibrosis patient by increasing the fluidity of the respiratory secretion. Now coming to these are the usage of amiloride other than the diuretic action in the cystic fibrosis patient. Now coming to the last group of group of drugs, osmotic diuretics. Example is mannitol. Others are glycerol isosorbide. Now coming to the mannitol, it is pharmacologically inert. Pharmacologically inert money? Pharmacologically inert money? It will not be absorbed, it will not be metabolized, it will be excreted unchanged. It will not show any effect. Right? So it is minimally metabolized in the body, freely filtered at the glomerulus, undergoes limited reabsorption, therefore excellently suited as an osmotic diuretic. Why osmotic? Because it exerts hyperosmolar action, draws fluid from the intracellular compartment into the extracellular compartment, so that more diuretic response can be seen. So mannitol appears to limit tubular water and electrolyte reabsorption in a variety of ways. Number one, it retains water isoosmotically in proximal tubule. Being hypoosmolar, when secreted in the proximal tubule, it draws more and more water and it retains water isoosmotically, dilates luminal fluid, which opposes sodium chloride reabsorption. Inhibit transport process in thick ascending limb of loop of Henle. It expands extracellular fluid volume, increases the GFR, increase GFR and inhibit renal release. They increases renal blood flow, especially to the medulla. So what happens? Basically, corticomedullary osmotic gradient is decreased. Through the primary action of mannitol, it increases urinary volume. Also, the excretion of cations and anions are increased, including all sodium, potassium, calcium, magnesium, chloride, bicarbonate and phosphate. It is not absorbed orally, has to be given intravenously. Now usage in increased intracranial or intraocular pressure, like in case of acute congestive glaucoma, it can be given. It can be given in head trauma, it can be given head injury, it can be given in stroke patient. Okay, to maintain glomerular filtration rate and urine flow in impending renal failure. Renal failure hote choleche, urine volume ekhonu maintained. In those cases, to maintain the urine volume, mannitol can be used. Okay, for example, in shock patient, severe trauma, cardiac surgery, hemolytic reaction. But when acute renal injury has been set in, urine volume has been decreased, in those cases mannitol should not be used. Why? Because mannitol, what does it cause? It exerts its action by as a hyperosmolar agent. It increases extracellular fluid volume, but urine is not being formed due to acute renal failure. What will happen? There will be fluid accumulation in the body. So if acute renal failure has already set in, kidney is incapable of forming urine even after an osmotic load, mannitol is contraindicated. Number 3, to counteract low osmolality of plasma or extracellular fluid volume in patients who have received dialysis due to rapid hemodialysis or peritoneal dialysis. In patients receiving dialysis or hemodialysis or peritoneal dialysis, there is a side effect called dialysis disequilibrium. Because of sudden withdrawal of fluid and electrolytes from the body, the hemodynamics of the person changes. So in those cases, to counteract low osmolality of plasma and ECF, mannitol can be indicated. Mannitol is contraindicated in acute tubular necrosis, in patients of anuria, pulmonary edema, acute left ventricular failure, congestive heart failure and cerebral edema, cerebral hemorrhage. The most common side effect is headache, nausea and vomiting can be seen. Now, these are urinary electrolyte pattern excretion via different diuretics. Number 1 is sodium. Maximum diuresis occurs with maximum natriuresis occurs with loop diuretics, then with thiazide and mannitol, then with other. Maximum kaliuresis is seen with acetazolamide. Now coming to the efficacy is maximum with furosemide and mannitol, intermediate with thiazide, and mild with acetazolamide, spironolactone and amiloride. Efficacy is low. Coming to the last basically group, antidiuretics. As the name suggests, its action is opposite to diuretics. It decreases the volume of urine. Now antidiuretics, more precisely anti-aquaretics, because they inhibit water excretion without affecting salt excretion, are drugs that reduce urine volume, particularly in diabetes insipidus. Diabetes insipidus mane? Sorry? Anyone from the back? Diabetes insipidus? They will polyuria. It can be due to the central cause. It can be due to the renal cause. Okay. Central cause মানে কি হয়, ADS secretion টা কমে যায় from the pituitary. So that is also called neurogenic diabetes insipidus or the central diabetes insipidus. And the second type is nephrogenic. Here the ADS is there in the body but is ineffective, not able to act on the kidney. So that is called nephrogenic diabetes insipidus. Okay. So basically, particularly in diabetes insipidus, which is their primary indication. Now what are the drugs that are used as antidiuretics? Number 1 is antidiuretic hormone, ADH, also called vasopressin, and desmopressin, lipressin and terlipressin. These are the drugs, number 1. Number 2 is thiazide diuretics. Thiazide diuretics normally increase the urine volume, urine excretion of water and electrolytes. Now here it is acting as antidiuretic, paradoxically. Amiloride, among the miscellaneous indomethacin, chlorpropamide, carbamazepine. Now coming to antidiuretic basically hormone, also called arginine vasopressin or denoted as AVP. Now it's a basically peptide hormone. It is secreted from the posterior pituitary. It is synthesized in the hypothalamus and then come down along the axon, stored in the posterior pituitary and secreted from it. Osmoreceptors present in hypothalamus and the volume receptors present in the left atria ventricus, they regulate the release of ADH governed by the body water status. Now osmoreceptors are also present in hepatic portal system that sense the electrolytes present in the blood and help in the release of the ADH or regulate the release of ADH. Impulses from baroreceptors and higher centers also basically regulate the ADH secretion. Now the human ADH is 8 arginine vasopressin, 8 AVP. Now there is also 8 lysine vasopressin that is found in swine. It is called lipressin and that has been synthesized by the human and is being used clinically in the humans. Other more potent and longer acting peptide analogues of AVP having agonistic and antagonistic action have also been prepared. Now ADH receptors or vasopressin receptors, these are G protein coupled receptors. Okay, and there are 2 types of vasopressin receptors. One is V1 and number 2 is V2. V1 again is of 2 subtypes, V1A, V1B. V2 is primarily present in the kidney. So all vasopressin receptors except those on renal collecting duct cells, ascending limb of loop of Henle and vascular endothelium. So V2 receptor 3টি জায়গায় রয়েছে, primarily on the renal collecting duct cells, in the ascending loop of Henle and the vascular endothelium. There V2 receptors are seen. In the rest of the places V1 receptor is seen. Okay. Now V1 is further divided into V1A and V1B. V1A is predominantly present in the vascular smooth muscle that is responsible for vasoconstriction. Okay, so it is present in the vascular smooth muscle, including that of vasa recta in renal medulla. They are also present in uterus and other visceral smooth muscles. In the interstitial cells of renal medulla, in the cortical collecting duct cells, adipose tissue, brain, platelet and liver. V1B receptor is primarily present in the brain, in the anterior pituitary, certain areas in brain and also in the pancreas. So V1A primarily in the smooth muscle, it can be vascular, it can be visceral. And V1B receptor primarily in the anterior pituitary, in the brain and in pancreas. And V2 receptor is primarily present in the kidney, in the cortical collecting duct cells, in the collecting duct cells and in the ascending limb of loop of Henle and also in the vascular endothelium. That V2 receptor causes vasodilatation by increased release of nitric oxide from the vascular endothelium, and V1A receptor present in the vascular smooth muscle cause predominant vasoconstriction. Now V1 receptors. V1 receptors are basically GQ type protein coupled receptors. So GQ type protein coupled receptors কিভাবে কাজ করবে? হ্যাঁ সরি জোরে বলো। IP3DAG pathway দিয়ে। So it will cause basically phospholipase C activation, IP3DAG pathway and cause increased release of calcium from the intracellular store, and that is responsible for vasoconstriction, visceral smooth muscle contraction, glycogenolysis in the liver, platelet aggregation by acting on the platelet, ACTS release and others. These actions are augmented by enhanced influx of calcium. Again, by activating phospholipase A2, these basically V1 receptor, they increase formation of arachidonic acid from the membrane phospholipid, resulting in increased formation of the prostaglandins and other eicosanoids, which contribute to many of the V1 mediated effect. Now, persistent V1 receptor stimulation will cause vascular smooth muscle hypertrophy. Now, V2 receptors, they are primarily present in the collecting duct cells and they are basically GAs, protein coupled receptors. They increase the formation of CAMP, cyclic AMP production, and they are primarily present in the collecting duct principal cells. Some V2 receptors are also present in the ascending limb of loop of Henle, and they are also present in the endothelium of the blood vessels. The V2 receptors are more sensitive to vasopressin than V1 receptors. So, in very low concentration of the vasopressin in the body, V2 receptors action will be more seen. But at the higher concentration of the vasopressin, the V1 action predominate. Okay. Now, some orally active nonapeptide V1A, V1B and V2 receptor antagonists have been produced. Like tolvaptan and mozavaptan are V2 selective antagonists. Now, basically is the collecting duct principal cells. These are V2 receptor, which is GH protein coupled receptors. There is increased basically formation of the CAMP, and further that leads to number 1, exocytosis of the water containing vesicles in the membrane, apical membrane, leading to more and more integration of the water channels in the luminal membrane. Again, they inhibit the endocytosis of the water channels and their degradation. Then in the continued use of the basically vasopressin, what happens? This causes increased formation of the water containing vesicles. Now again, they also increase this excretion of urea from the collecting duct by stimulation of the urea transporter. Now these are also present in the thick ascending limb of loop of Henle. They are causing activation of the sodium potassium chloride channel. V1A receptor is present in the vasa recta, that is responsible for vasoconstriction. We know they are present in the collecting duct principal cells. What happens? Because of more and more integration of the water channels in the luminal membrane, more and more uh, basically more and more water will be accumulated in the body. So AVP acts on the collecting duct principal cells to increase their water permeability. Maximal. So what happens? The osmolarity of the urine is increased. Maximal osmolarity of urine that can be attained is 4 times higher than that of plasma. Now, vasopressin is instrumental in rapid adjustment of water excretion according to the state of body hydration. V2 subtype of ADS receptors are present in the basolateral membrane of principal cells in collecting duct cells. Now, they promote, already discussed hoye geche. To achieve maximal concentration of urine, activation of V2 receptor increases urea permeability. We have seen that V2 receptor activation also increases the urea permeability in the collecting duct cells, and they augment the medullary hypertonicity. More and more urea is being basically excreted, medullary hypertonicity will increase. Recently, V2 receptor mediated action of AVP on ascending limb of loop of Henle is also seen that increases the medullary hypertonicity. Now, activation of V1 receptor in the vasa recta basically cause vasoconstriction that diminish the blood flow in the inner renal medulla, and they are increasing the medullary hypertonicity. Action on the blood vessels. Vasopressin, they constrict blood vessels through V1 receptor and can rise blood pressure. The cutaneous, mesenteric, skeletal muscle, fat, depot, and the thyroid and the coronary beds are all vasoconstricted. Now, they may play a role in congestive heart failure, hemorrhage, and hypotensive states. Because of vasoconstriction, the blood pressure can be elevated there. Prolonged exposure to vasopressin causes vascular smooth muscle hypertrophy. V2 receptor mediated vasodilatation also occurs, but that action is masked by the basically V1 receptor action. Other action, most visceral smooth muscle contracts in uterus, they cause uterine contraction. In the CNS, generally it cannot cross the blood-brain barrier, but in the brain as such they act as peptide neurotransmitter. In the platelet, they cause platelet aggregation. In the liver, they are causing hepatic glycogenolysis. And in the endothelium, they are helping in the release of von Willebrand factor and the factor 8. Now, pharmacokinetics, generally they are not used orally because they are destroyed by the trypsin enzyme, so they are used parenterally or by an intranasal route. Now, coming to the vasopressin analogs, number 1, lipresin, also called 8-lysine vasopressin. Their action is similar to that of vasopressin, normal vasopressin that are present in the body, but they are longer acting, number 1 thing, and number 2, their action is the efficacy is lower. They basically they show both V1 and V2 receptor mediated actions. Now, terlipressin, they are primarily used in the bleeding esophageal varices. Okay. Desmopressin is a synthetic vasopressin analog that is a selective V2 agonist. They are longer acting compared to the other analogs. They are the preparation of choice for all V2 receptor related indications. Now, they are present in 2 routes, dosage formulation. One is intranasal route, that is more preferred, and oral route is also available. Intranasal route is preferred, though bioavailability is only 10 to 20%. Oral formulation is being marketed with a bioavailability of 1 to 2%. Now, these are the uses of vasopressin based on V2 actions, based on V1 action. Based on V2 action, কোথায় কোথায় use করা যেতে পারে? Diabetes insipidus is the primary indication, number 1. Number 2, bedwetting in children. In the nocturia in case of adults. Renal concentration test, it may be used. Hemophilia and von Willebrand factor disease deficiency. Now, based on V1 action, bleeding esophageal varices is the primary indication and also can be used before abdominal radiography. Now, coming to diabetes insipidus. Diabetes insipidus of, now there are two types you know, neurogenic diabetes insipidus and nephrogenic. It is used only in case of neurogenic diabetes insipidus. Why? Because in neurogenic diabetes insipidus, ADS release is not there. And in case of nephrogenic diabetes insipidus, ADS is there, but it is not able to act on the kidney. So, if in case of nephrogenic diabetes insipidus, we give further vasopressin analogs, no action will be seen. So, it is used primarily in the diabetes insipidus of pituitary origin. It is ineffective in renal diabetes insipidus. Lifelong therapy is required, except in certain cases where there is transient diabetes insipidus, like in case of head injury patient, in case of stroke patient. Okay, the dose of desmopressin has to be individualized by measuring 24-hour urine volume. It can be used in aqueous vasopressin and lipopressin injections are impracticable for long-term therapy, can be used in transient diabetes insipidus, and to differentiate between the neurogenic and nephrogenic diabetes insipidus. Now, intranasal or oral desmopressin at bedtime, they control primary nocturia and in adults and nocturnal bedwetting in case of children. Fluid intake, but in this case, fluid intake should be restricted 1 hour before and 8 hours till 8 hours after the dose, so that dangerous fluid accumulation is not seen. The blood pressure and the body weight should be monitored to get an idea about the fluid status in the body, and after every 3 months there should be a drug holiday for 1 week, so that the status of the person can be assessed. Renal concentration test, 5 to 10 unit IM of aqueous vasopressin or 2 microgram of IM desmopressin causes maximum urinary concentration. In hemophilia and von Willebrand disease, desmopressin is a preferred preparation. They increases the release of factor 8 and the von Willebrand factor from the vascular endothelium. Now, coming to the bleeding esophageal varices, is a V1 receptor mediated action. How does it stop bleeding? They causes mesenteric vasoconstriction, and thus the blood supply to the liver is decreased. So there is less bleeding from the esophageal varices. It has replaced ABP because of fewer adverse effect and greater convenience in use. Now, what the treatment of choice in bleeding esophageal varices? Anyone? Is a surgical treatment, basically endoscopically sclerotherapy of the esophageal varices. Now, the drugs pharmacologically that can be used to treat is vasopressin or terlipressin, not desmopressin. Is vasopressin or terlipressin, also octreotide, which is a somatostatin analog, can be used alternatively. However, definitive therapy for varices remains endoscopic obliteration by sclerotherapy. Before abdominal radiography, AVP lipopressin has been used occasionally to increase in expulsion of gases from the bowel. Now, because of V2 selectivity adverse effect, desmopressin causes fewer side effects than the other vasopressin analogs. However, transient headache and flushing may be seen. Due to nasal application, there may be nasal irritation, congestion, rhinitis, ulceration and epistaxis. Fluid retention, hyponatremia may develop. Now, AVP due to cardiac effect can cause bradycardia, increased cardiac afterload and precipitate angina. Why? Because of coronary vasoconstriction. So the drug is contraindicated in ischemic heart disease patients. In hypertension, chronic nephritis and psychogenic polydipsia also the drug is contraindicated. Thiazides we all know, so the diuretic action, but paradoxically it exerts antidiuretic effect in diabetes insipidus. Unlike vasopressin, they are useful in both central and peripheral diabetes insipidus. So, however, their efficacy is low. Urine can never become hypertonic. So, in case of central diabetes insipidus, desmopressin is the drug of choice because thiazide is not that effective. But thiazide can be used in nephrogenic diabetes insipidus where vasopressin is not effective. The mechanism of action is not understood. Thiazide induces a state of sustained electrolyte depletion that may be responsible for the effect. They also reduce GFR and thus it can also show antidiuretic action. They are less effective than ABP, more convenient and cheap for pituitary origin DI. Other antidiuretics, amiloride, they are drug of choice in lithium-induced nephrogenic diabetes insipidus. Indomethacin, they decrease the formation, they basically decrease in the formation of prostaglandin and thus reduce polyuria in renal diabetes insipidus. Chlorpropamide is an oral antidiabetic drug. They reduce urine volume in diabetes insipidus of pituitary origin, but not in renal diabetes insipidus. Carbamazepine is an anti-epileptic and they are useful in the central diabetes insipidus, not in renal. Vasopressin antagonist, tolvaptan is an orally active non-peptide V2 receptor antagonist primarily used to treat hyponatremia due to congestive heart failure, cirrhosis of liver and CAD. Thrombotic complications can be seen due to hemoconcentration. The most frequent side effects are thirst and dry mouth. Mozavaptan is a V2 receptor antagonist, conivaptan V1A V2 receptor antagonist.